So it's always interesting when psychiatrists and surgeons get together, I think. The last time I can think of that, I've just seen a member of the audience. It reminds me of when I was on a plane coming back from a flight recently, and this person in front of me seemed to be having a lot of trouble with his son's nosebleeds, and there's blood everywhere. And I just couldn't resist. I sort of went to the chair in front of me and said, look, if you want any help with your son's nosebleed, I'm a doctor. And he turned around and said, yeah, it's okay, I'm a surgeon. And he was clearly monitoring the blood loss, even though he looked like he was not doing much. But so with that, let's go into the topic, which is, thanks for asking me to talk about the personality and psychiatric factors associated with obesity. And this is a really interesting but somewhat depressing area, I think. So my specialist, I'm the director of the Eating Disorder Service, so most people I see have the opposite problem, anorexia nervosa. But we also see a lot of people with bulimia nervosa, binging and purging. And we see more and more people with binge eating disorder, where they lose control and eating large amounts of food in short periods of time, and that causes a lot of distress and shame for them. Obesity itself, of course, is not. We don't classify it as an eating disorder. It's really a statistical variance, but there can be a big overlap between obesity and binge eating disorders. The psychiatric conditions that we see associated with obesity are binge eating disorder, which is quite common. Up to 11% of the population can have binge eating disorder. Depression, which 20% of the population will have a depressive episode at some stage in their life. Most people with depression lose weight, but there are a small group who overeat and have increased appetite when they have depression. And also borderline personality disorder, which is a disorder where a person usually as a result of early childhood trauma, including sexual abuse, develops difficulties in self-soothing and regulating emotions, and comfort eating is a great way to deal with those painful emotions. So we do see quite a bit of that as well. People with schizophrenia have 20 years shorter lifespan than people not with schizophrenia, and most of that's due to obesity. And a lot of the blame is with the medications that we've developed. Unfortunately, there is a lot of weight gain and increased appetite associated with those. So that's where we see obesity, and for us it's a really important issue in psychiatry. But most obesity is actually not caused by psychiatric conditions or psychological issues, or lack of willpower, or some other character weakness for that matter. You know, there is still a lot of humour and innuendo that fat people must some way be weak. I think that's a general belief or intuition, even though the evidence doesn't really support that. Now, I didn't get to hear Dr. Kevin Lee's talk earlier, but I do want to talk about some endocrine issues. So please put your hand up if I'm repeating old stuff in the next few slides. This was in 6 Minutes, which is the GP newsletter. It was just 2 weeks ago. Doctors slam patient blaming portrayal of obesity. Doctors and allied health professionals have slammed media outlets for encouraging patient blaming portrayals of obesity. 21 doctors, including endocrinologists, have signed a statement calling for the media to offer the same empathy and respect as a patient living with any other serious chronic condition. Obesity can be influenced by environmental, psychological and physiological factors, along with genetics and genetic causes, which all play a role in a person's ability to balance their consumption and activity. The statement reads, "Public discussion on obesity should be solutions-focused rather than patient-blaming." Endocrinologist Professor Joe Proietto, was any of his research presented earlier today? No, I'm going to talk a fair bit about his findings. Who co-signed the statement, said evidence published in the last decade has increasingly questioned the idea that obesity is all about poor self-control and people being gluttons. The discovery of leptin and ghrelin as hormones that control the hunger response are examples of work that is changing the way researchers are looking at obesity. Professor Proietto has called for greater education of the media. The media should be acknowledging the fact that obesity is not all about self-control. They can help us convince politicians to stop advertising junk food to children, which Dr. Hope was just talking about earlier, prevention in children. But there needs to be education for doctors too, because many of us were trained before these new findings about obesity came to light. And we often say to patients, you need to go away and lose weight. But what we're going to hear, and maybe you've already heard, it's not that easy. In fact, obesity is not usually caused by psychological problems, I would argue, but it often results in psychological problems, and that's mediated through society's blame, and that starts in the schoolyard. Our society harshly judges fat people as somehow morally weak and encourages them to diet, which is actually ineffective, harmful, and often counterproductive. Extreme dieting can make both obesity and mental disorders such as binge eating disorder and depression worse. What causes eating disorders? This is the best model we have in psychiatry to date, which is Christopher Fairbairn from Oxford's Transdiagnostic Cognitive Behavioural Formulation. And so he argues that all eating disorders, binge eating disorder, where there's overweight, anorexia nervosa, where there's underweight, and bulimia nervosa, where there's a binge purge cycle, are caused by similar cycles. And just find the important thing I want to point out here, the strict dieting and being low weight is one of the biggest drivers for binge eating. So the most common cause for bulimia nervosa and binge eating disorder is people trying to lose weight. And that can lead to a vicious cycle. So we have a lot of patients come to us who've had 20 years of bulimia or binge eating, and we put them on a regular, balanced, adequate diet for the first time ever, and they recover within a year. And so it's the opposite of what they're trying to get them off that treadmill. Now, of course, binge eating is also emotionally comforting. It fires off dopamine in the brain, so mood changes and events can also lead to binge eating. It can be a way of managing, just like alcohol can, a way of managing negative emotions. And if you've had early childhood attachment difficulties or trauma, you're going to have a lot more negative emotions and difficulty soothing yourself, so you're much more prone to binge eating. This is the manual we use, Cognitive Behaviour Therapy and Eating Disorders, which has a 70% effectiveness rate for binge eating disorder. It involves 21-hour treatments. And at our service at the Royal, we have clinicians trained by Fairbairn from Oxford. So it is a very effective treatment. It can also be used as bibliotherapy, where the patient, especially if they're intelligent and educated, can read this book, do the exercises, which is regular diet, and they can ameliorate the binge eating disorder. But the bad news is they don't lose weight. So what happens is it reduces the loss of control, the shame, the guilt, the depression, the anxiety, the compulsive thinking about food, and they are happier, but their weight is the same. And often they're okay with that, but often a lot of people around them are not. Fluoxetine 60 to 80 milligrams is also helpful for reducing the obsessiveness and the binging. But still, we're not addressing the obesity. So I've been on the executive of the Australian New Zealand Association for Eating Disorders for about 8 years, and at a congress in Melbourne in 2013, we invited Professor Joe Proietto, who's a world obesity expert based in Melbourne. And I found his explanation of why our patients struggle with losing weight to be very coherent and cogent. And he speaks a lot in public settings, and members of the public find his explanations helpful too. So I'm going to quote a bit from what he says. The reason I'm harping on this really is so that we don't create psychological problems and more shame by telling patients to do things they can't actually do, or that we couldn't do either. So his key messages were that obesity is the scourge of the 21st century. That's one reason we're all gathered here. Most people believe that the only cause of obesity is a poor lifestyle. In fact, there is very good evidence that to become obese, it's necessary to have a genetic predisposition. This has been demonstrated by identical twin studies and adoption studies, and many genes causing obesity have already been discovered. Weight loss improves health issues associated with obesity and leads to improvements in the quality of life. It follows that most obese individuals should lose weight. The problem is that the failure of weight loss programs is very high. People can lose weight for maybe a year, but after 5 years, it's less than 5% the success of people actually keeping weight off. Joe Proietto presented this very depressing study called the Minnesota Heart Study. He explained at the conference that this was the biggest ever public health campaign, multifaceted, to try and reduce obesity in a population. So there were 3 intervention cities in the US and 3 control cities. And for the intervention cities, it was a 9-year intervention. The study went for 13 years. They had risk factor screening, mass media education. They basically threw everything that was, in the kit bag to try and reduce obesity, all the things that thought maybe could reduce it. Adult education classes, worksite interventions, home correspondence programs, school-based programs, restaurant programs, point-of-purchase education in supermarkets, that's interesting, messages about benefits of weight loss, and also all the services available to assist people to lose weight. I think you know what the next slide is going to show. what that slide shows that over 9 years there was absolutely no difference between the control groups and all that money being thrown into public intervention. And still, of course, we go and do it. Our own DG, not sure if she's here, but has been throwing money into stuff that really there's not much evidence for. It just makes people feel bad about themselves. So why does education and dieting fail? Because most people know obesity is bad, they want to lose weight. And as Prof Proietto explains, it's the brain that regulates weight, and the hypothalamus has two types of nerves, as he fairly simplistically explains it. The neuropeptide Y that makes us hungry, and POMC that takes our hunger away. And that rate of firing is influenced, we know now, by hormones such as ghrelin, ILP5, and leptin. And like the orthopedic surgeon before me, I'm stepping a little bit out of my expertise here, but I found this very interesting. Following the weight loss, levels of multiple hormones, all of those up to 9 hormones, change in direction dramatically to encourage defense of that weight regain. So really we're evolved that if we put on weight and then we lose weight, to bounce back up to the higher weight again. You can see maybe the evolutionary advantage of holding onto weight. But if you lose weight, your hunger will increase, your energy and expenditure will reduce due to the insulin-related changes, and your food intake increases and your weight will be regained. And unfortunately, there's lots of studies to support this and why this may be. He said for a public health program to work, and none have, this is what you would need to do. Re-engineer society to restrict high-energy food by placing a ban on and severely taxing all fatty or high-sugar foods, and many of us, including me, would agree with that. But then placing the population on energy rationing. You need to ration because if you're already obese, you can stay obese by overeating healthy food. And here we're talking about the ineffectiveness of weight loss, which is a different matter to preventing obesity, I guess. In addition, physical exercise would need to be obligatory, ban cars, escalators, elevators, slow the pace of modern life so people can walk to meetings. All of this is impossible to achieve in a democracy. There's maybe North Korea, we could do this, but we're not North Korea. Now, there's been some great animal studies. This is one of a series of studies looking at creating and treating obesity in rats. This particular study, rats were given extra food, which is this highly palatable corn syrup, which is something rats love apparently. And it's very similar to a lot of the sweeteners that are put in American processed foods. And condensed milk, and these rats quickly become obese. They just love the stuff. Then they put the rats on a diet so they would lose weight. They also had a control group of rats that weren't given this high energy, highly palatable food. Now, when they let the study experimental rats eat as much as they wished again in a natural environment with just healthy food, they went back to their obese weight, whereas the control rats didn't stay obese. So rats and humans, we seem to return to our set point after dieting. And there are more and more studies coming out now, mainly in the psychiatric and eating disorder literature, showing that whatever weight is being your ever highest weight, if you reduce below that, you start to get obsessive thinking, binging, purging, and it does affect your brain functioning. So we're really in trouble here, I think. I'm going to show some more of what were my assumptions, and maybe some of yours as well, which is, there's a strong genetic contribution to obesity. And the way Proietto explains it is that, sure, we have a different environment ever since the 80s with, highly processed foods and being inactive, but some people genetically are prone to just become super obese. And there have been these studies looking at the body mass index of twins who've been reared apart. This is the best way to, look at genetic influences. So here, this particular group looked at 93 identical twin pairs reared apart, so the same genes for different environments, 154 identical twin pairs reared together, so same environment, same genes, and then the same with non-identical twins. What they found was the shared family environment, in other words, a family where there was a lot of... Okay, we could be finishing soon. So an environment where there was a lot of food and not much activity did not predict obesity. Genes did. The twin from a fat biological family who was adopted out to a skinny food conscious family still became fat, and the skinny gene kids adopted into fat families stayed skinny. One of the genetic things inherited, he explained, was fidgeting. So exercise is a very inefficient way, voluntary exercise, to lose weight. So if you sit at a computer for 12 hours and go to the gym for an hour, not very helpful. But if you naturally fidget, which is genetically inherited, and some people do, you're less likely to become obese, even in an obesogenic environment that we live in. And there's been similar findings in other twin and adoption studies. So why is treating obesity so difficult? And here we have Dr. Proietto arguing for bariatric surgery, which is what I'm going to be arguing for too, actually. There is little evidence that public health measures adopted so far have had any impact on the rise and the prevalence of obesity. Weight loss programs have a very high long-term failure rate. There's emerging evidence that weight is regulated by the hypothalamus and is physiologically strongly defended. 5 minutes, thanks. There is also a strong genetic predisposition to the development of obesity. And the availability and promotion of high-energy foods and the absence of any obligatory need for physical activity compound the problem, that's for sure. But this social change is not easily reversible, especially in lower socioeconomic group areas and suburbs where there's just heaps of franchise foods and not many parks. One way forward is to focus public health measures on preventing obesity in children, which is what Dr. Hope was just saying, and I agree with that, while making resources available to treat people who are already obese, but evidence-based treatments like bariatric surgery in public hospitals. I have one patient, for example, I've seen who has done a year of cognitive behaviour, who's got morbidly obese, has had a year of cognitive behaviour therapy, a year of very good dietetic work, does all the homework. She had early trauma. She's got arthritis in both her knees, but she's got no money for private bariatric surgery, and I can't access public bariatric surgery. So I think his argument is there should be more funding for that. Dieting is dangerous. It's bad for you. It causes, I can't watch The World's Greatest Loser, knowing what it does. Most of our patients are victims of diets, and my colleague Shane Jeffrey in our team will talk more about this soon. But there's overwhelming evidence that dieting causes binging, weight gain, and eating disorders. We all know about the rebound weight, and we sort of understand the hormonal reasons behind that now. So one study of 17,000 kids, 9 to 14, dieting predicted weight gain, not weight loss, a 5 to 12 times increase in binge eating, and the long-term dieting to control weight is not only ineffective but promote weight gain. Now I should argue by dieting I mean non-sustainable 1,000 kilocalories or less, that sort of dieting. What lifestyle changes is useful. And there are many other studies. Here, one Mann et al. Looked at 31 long-term studies on effectiveness of dieting. 2/3 of dieters gained more weight than they lost. So dieting is not the answer. As I say, we can treat binge eating disorder. We stop people dieting, paradoxically. And so there's more a move now to focus on health and lifestyle, not weight, because by having a healthy diet and a good active life, and also not hating your body, and being on that diet cycle for many years, you can actually have a better life and have greater well-being. So there's a health at any size movement, which is about having a healthy, diverse, enjoyable diet, an active life, no fat-shaming, bullying, exhortation to diet, or as we call it, torture size, that grim, I'm going to exercise 3 hours until Christmas a day. Embracing diversity in the schoolyard and focusing on well-being, including mental health and social connectedness. So in our team, we really work on that because we're seeing a doubling of all sorts of eating disorders from primary school children coming into our clinics. And there have been some great guidelines written for how you can prevent childhood obesity and prevent developing eating disorders by this group. So if you look up the Academy for Eating Disorders, there's a great literature review on that. I also just want to raise the issue, are we overreacting? There's an aesthetic issue in that most of us would say a healthy person is someone who's about a BMI of maybe 19, which actually, according to the curves, that's not healthy. It's just aesthetically pleasing, which is a difference. And a systematic review and meta-analysis, I apologise if this was presented before, and JAMA looked at 2.88 million individuals. This is the biggest meta-analysis of the relationship between BMI and mortality. And what it found is that being overweight between a BMI of 25 and 30 is associated with the longest lifespan. Now, there could be all sorts of confounding reasons for that, but the idea of a spare tyre, it's good to have a spare tyre, especially as you go into older age. Whereas, normal BMI, 20 to 25, is pretty healthy, so is even obesity, but it's the over 35s where we're getting health issues. So often health campaigns target on people who are overweight because they could head into obesity, but maybe we're just overreacting a little bit. Last slide. Looking to the future, these are just some thoughts. I agree with the previous speaker that preventing childhood obesity, prevention is our biggest challenge, and maybe looking at legislation and advertising about harmful foods and being promoted to children. There has been some early work with psychostimulants. I've got an I guess, a declaration of interest here. I'm on the board of a company, Shire, looking at use of psychostimulants for binge eating disorder and reducing weight. Controversial area, but it's being explored and has been approved in the US. Bariatric surgery is by far the most impressive treatment for reducing the physiological and psychological effects, and a few of my colleagues have been working with bariatric surgeons and getting impressive results, but it's not available to all socioeconomic groups. Embracing and tolerating diversity, especially in schools, and awareness of the dangers of dieting and fat shaming. Thank you. I've raised lots of questions. I haven't given you many answers, probably. Yes.
Have not changed.
Just so everyone can hear you.
Have not changed. Our genes in the last 2 to 3 generations have not changed in a major manner. You use the words an obesogenic environment. And I think you would agree that is the major factor rather than a genetic change.
Yes. This very question was asked of Professor Proietto, and because I had the same question myself, and his answer to that was, yes, since the 80s there have been massive changes in the amount of high-calorie foods available, the advertising of those, low activity, especially since the early 80s. But there are some in the population who are genetically predisposed to being very vulnerable to that environment, and they're the really morbidly obese folks we see, and there are others who are maybe getting a bit overweight but not obese.
If you looked at our vascular ward in 1975 here, 90% of the patients smoked. 10 to 15% of the patients were diabetic. It's now the reverse, in the sense we've now got 80 to 90% of the patients in the vascular ward who are diabetic.
Yes.
I could go to a meeting at this hospital with the chairman of the hospital board, the medical superintendent, the director of surgery, the deputy director of surgery, and they could all smoke in my presence, and it was socially acceptable. And if I said something about it, I was socially unacceptable.
Yes.
We can now have situations here, and we've turned a lot of the reason I think we've changed the attitude to smoking, and we have a huge impact, because all of a sudden we haven't worried about the guilt factor of making people guilty about the fact that they used to smoke too much and smoke cigarettes. I can't see us changing much until we take the same attitude towards obesity, because at the moment it is socially unacceptable to express any attitude of lack of acceptance or the cause of obesity.
I think what Proietto says is that by 3 years of age, that is set in. So if we want to target an age group at 0 to 3 with the environment, by then the horse has bolted largely, and dieting doesn't work. So people shouldn't smoke, but there weren't many treatments once they got lung cancer. Except once you got lung cancer, it's too late. So that sounded a bit jumbled, I realised. What I meant to say was, we do need to focus on the environment, but for less than 5 years old, because once someone is obese, apart from surgery, there are not many effective treatments.
Sorry. Thanks a lot for your talk. It's very interesting. I think some of the things you say is true, but I think some of the things you said is probably based on theory. First and foremost, if it is genetic, how come 67% of Australians are overweight or obese? But that doesn't just happen overnight, does it? Secondly, you said something about twin studies and the like, but twin studies are a very homogeneous example. Australian populations are very heterogeneous. How come 67% of the population is overweight or obese? $87 billion industry. I think when it comes down to it, I grew up in the Solomon Islands, but born in Solomon, grew up in New Zealand. I can tell you that this is, in the majority of cases, is environmental. You go to Honiara, same population, go to the village, different. 80% of Honiara is obese or overweight. 20% of the village is obese or overweight. How can you explain this if it's genetic? It's environmental.
Yeah, so I think it is environmental and genetic, and it's complex. And what I didn't show was some studies also done with rats where you can actually get fat rats, and they were more likely to eat more. And yes, yeah, sure.
Somehow someone has to tell us that we are overweight. I can tell you, at one point I was 146 kilos. And I was a doctor then. My mates don't want to tell me because they think that they might embarrass me. Until someone told me that I had a problem, I thought I didn't have a problem. And when they told me that I was overweight, I was a doctor, that's when I decided I need to do something. Sometimes someone has to tell us we have a problem. Now, just saying that people don't have a problem, making them feel good about themselves, this problem is going to get worse. Since the 80s, it's going like this. If we continue to do what we're doing now, it was going to go up. 80% of Australians will be overweight or obese. We have to do something. I know it's not simple. It's not something that is one answer to this, but it has to be multifactorial, and we have to start with us doctors. We have to make that comment every time we see a patient. Have you thought about doing something about the weight? I often talk to my patients. I told them that we need to talk about lifestyle. So it is a lifestyle change. My opinion is that it is a lifestyle change that makes us big. It has to be a lifestyle change that makes us small. There is no easy way. Lifestyle changes are not easy. Most people want easy. I just had a chat to Dr. Hopkins, and he's saying that with surgery, it works in the first 3 years. After that, it doesn't work. Because the problem is that we don't have the change. We don't have the lifestyle change. That's why we need mentors. It's something that goes federal, state, as well as local. But we as doctors have to be the example. I feel quite embarrassed for smokers that we now ostracize them. What's the problem with smokers and obese people? I mean, what's the discrimination? That's discrimination there right in front of us, and we are condoning it.
I'm not sure we have the answers to all those questions, but one last question here for Warren.
Could we go back to the slide showing the lifestyle changes, please?
This one?
Yes, that's the one. I think that answers most of our questions, doesn't it? It's got to be a lifestyle change, and it's got to be a diverse lifestyle change.
I think I'm all for lifestyle improvement, because it improves lots of things, improves your lifestyle and your happiness and your well-being. It would be good to get some really good evidence-based lifestyle changes that lead to weight loss. It has been studied. There have been lots of studies. 90% failure rate over 5 years is the data so far. I guess the challenge is to all of us to try and improve that. But in the meantime, bariatric surgery is getting much better results.
Could I suggest that that's not just a 12-month or a 3-year or a 5-year change? It's got to be a lifestyle change.
Yeah, and results over 12 months are a lot better than they are after 3 years or so forth. So we get a lot of rebound, which fits in with what we understand about the hormones. So yeah, I realise I'm bringing bad and frustrating news to you. This has turned around my thinking from, you just need to lose weight was my thoughts. But the more I've looked into it and heard from my colleagues of experts in this, it's not that simple.
Well, thank you, Warren.
Thank you.
Thank you very much.
Thank you.